Good morning. Sorry for the technical glitches here. I hope you're all able to hear and see what I'm presenting. I'm with my partner, Dr. Ismar Dizdarevic, and we're going to be talking to you about the latest trends in hip and knee replacement. We'll have a brief discussion about arthritis, which is the condition we're predominantly treating. I will talk about joint replacement surgeries, and then we're going to get into the nitty-gritty of this discussion, which is about robotics and why and what they actually do. And then we're going to talk about whether robotics are actually beneficial. We'll talk about risk factor modification for patients, about discharge, and then we're going to address the elephant in the room, which is COVID-19. So we're talking about arthritis. We're talking about disease of the joints, primarily the hip and knee, and it basically can affect every activity you do, getting up in the morning, walking around, working out, walking your dog, and going to work. This may bother you whether you're sitting, getting up, standing, walking, doing anything, getting in and out of the bathtub or the shower. The pain from arthritis can be constant or maybe episodic, can come and go. Often it's worse after you've been sitting for a while and not doing anything. And it can be located in one spot primarily, or really could be throughout your body. But more than 30 million Americans suffer with arthritis, and for people still working, it affects their ability to work. But for a lot of people, it affects just their normal activities at home, what they can do, going up and down stairs, taking out your trash, and then leisure activities, walking, riding a bike, golf, etc. Rheumatoid arthritis is another condition, affects more of your body, and usually involves the care of a specialist, a rheumatologist. And unfortunately, for more common in women, what's kind of unique is it can really occur any time in life. A lot of people get diagnosed later in life, but ultimately, people with rheumatoid arthritis can develop regular osteoarthritis, and they end up having similar treatments. The arthritic knee, if we just look here, is a diagram of a knee. We see there's the femur, the thigh bone, the tibia, the shin bone. They come together and they're both covered with cartilage. And healthy cartilage, meeting healthy cartilage, is very functional. That's why we see young people running around, playing sports, etc. It works very well. Unfortunately, when you injure it, you see here this area, diseased cartilage, it's red, that doesn't get better, that progresses. The cartilage does not heal. On this x-ray, you see a clear space on the x-ray on the left. That's healthy cartilage. You see over here that clear space is gone, and you start seeing these bone spurs, and that's arthritis. On the hip, it's the same concept. It's this hip socket, or we call it the acetabular, part of your pelvis, which you see here. And then when it gets diseased and you're losing that shiny white cartilage, and which is on the top of the cartilage is in the socket. And it's also at the top of the femur bone. It's the ball of the hip is covered. So here you see on the left, you see a good looking x-ray, clear space cartilage. You see here that clear space is gone. You see that dark white, the bone actually gets thicker and denser. It's called sclerosis. And you start seeing these little spherical structures. These are cysts, and that's normal part of arthritis. And for some people, the arthritis is after trauma. You have an injury, and years later, it could start the progression to arthritis. Hip and knee pain is really variable. If you have hip arthritis, the pain can be in your groin, your thigh, your buttock. It can radiate down to your knee, and you may not always feel pain. Some people just have stiffness. And for some people with hip and knee arthritis, it actually wakes them up at night when they move around. It can be difficult. And sometimes it's difficult to determine whether, if you have knee arthritis, but could the source of pain be the hip or the back? And the same for hip arthritis. Could the source be coming from the back? In general, non-surgical treatments, exercise, weight loss. For people, taking off 1 pound of weight is 4 pounds off your knees. Other non-surgical treatments are walking aids, heat or cold. A lot of people like some of these menthol gels, and these provide a little bit of relief, more so the knee than the hip. Some people don't want to use a cane. You can use a trekking pole or a walking stick. And then there's medications. Tylenol is really typically the safest one. You just got to watch the dosage you're taking as it's written on the bottle. Non-steroidal anti-inflammatory drugs, or NSAIDs, which are Advil, Aleve, or the prescription Celebrex or meloxicam. Those are often very helpful. They reduce pain and swelling. And then we often do injections, cortisone injections.
Sorry, Dr. Pizzurro, just to interrupt you, we are seeing only the topic slides still. So if you don't mind just clicking through your slides are just showing the topics. There you go. We can see it now.
You can. Sorry.
Yes, yes. It's good now.
It's good now. Which slide were you on?
Topics.
Oh my gosh. All right, sorry.
Could you tell me what screen to go to? What page?
So right now we're just discussing arthritis. Basically what I'm going to get into here is we're going to talk about hip and knee replacement. And we're going to talk about robotics. Are you seeing, which slide are you seeing now?
Non-surgical treatment options.
Okay. And you're seeing that, did the slide advance now?
No.
Very weird. Non-surgical treatment, what are you seeing? Okay. And I go like this. Sorry, guys. Yeah, you're right. Okay. So, here we go. So, non-surgical treatment options, aside from pills and injections, there's physical therapy to mobilize your joint. Physical therapy, it's important. For some people who are active, maybe less useful, but for people who are not very active, it can really help to get you moving. And physical therapy in that regard is beneficial. No way. So big topic today is robots. Robotics started in orthopedics in around 2006 with partial knees, then 2010 with total hips, and in 2016 with total knees. And Valley, just over 2 years ago, started a program with using the Stryker Mako robot. This here, you see 3 robots. It's actually the same robot, and what changes is that hand piece. So, you know, you might think here, you know, if rodents thinker, or you got just the classic emoji, you know, how do we get here? In my lifetime, at some point, this rotary telephone was useful. We could talk to people in Europe or Australia if you wanted to. We had cameras for a century that worked, and all of a sudden we had digital cameras in the late 90s and early 2000s, and we thought that was the best thing. You didn't need to get better. Then we came out with, you didn't need a rotary, you didn't need a telephone, a landline, you have your cell phone. And eventually we got cell phones that give you pictures, calendars, maps. You can navigate, you could basically do anything. You could do your banking or anything you wanted. And that's kind of where we've come about with robotics is computers and robots can do things very accurately. They give us information we're not normally getting with standard instruments. And that's how we advance and come to this point. Dr. Dizdarevic is going to step in here and talk to us some about knee replacements. Can you click on share screen? I'm going to say stop sharing.
Okay, everybody can hear me?
Yes.
Yep.
But we don't see your screen.
Yes.
I don't think anybody can hear me. I can hear anybody else.
Are you guys there? Can you hear me?
Yes.
Yeah. Okay. Well, I hope everybody can hear me. So like Dr. Pizzurro said, my name is Ismar Dizdarevic. I'm one of the newer partners here at Ridgewood Orthopedic Group. So I think just a little introduction to who I am. While it is a very common North Jersey name, I've been asked, you know, where I'm from often. And I think the first topic is going to be that the name Dizdarevic was recently brought to my attention to actually in Turkish mean knee. So I think I have a pretty good, a vantage point of talking about knee replacements, and just recently having found out that my name itself means knee. So my little section will talk to you about specifically total knee replacements and how we ended up at this point in time. So very quickly, total knee replacements are the fastest growing expenditure in Medicare right now, and oftentimes that is coupled to private payers as well. And if you kind of do the little diagram, you can see that very shortly we're going to be doing over 1 million knee replacements a year in this country. Globally, that number is even higher. And as the population ages, our ability to provide a durable knee replacement becomes more and more critical. So that's what I was trying to find, if it does it. So I click share desktop. Is it sharing now?
No. Just waiting for it.
Sorry, guys, we're just trying to figure out how to share our desktop.
So on the taskbar, there should be a little box with an arrow going up. Okay, hold on. I see it. I'm going to share it with everyone just shortly.
Yeah. You see now? Does that show up or no?
Yes.
Now it does? Okay. Maybe if I do that. Okay. So the biggest issue that comes across from seeing this kind of exponential rise in total knee replacements is that the number one payer in this country has changed the way that these surgeries are paid for, both to the orthopedic surgeons as well as to the hospital networks. And this is really meant to try to kind of contain this very dramatic rise in volume. And in the past, I think most people can remember probably even 10 years ago, you would see your doctor, the doctor would submit a bill for that face visit. Today, the surgeries are built very differently, and it's something that we call value-based care. So value at its very basic definition is benefit over cost. So if you can increase the benefit, you will increase value. Likewise, if you can decrease costs, you can also increase value. So the payers, which is essentially Medicare, have decided that they're going to begin the process of trying to decrease the costs because there's such a large number of hip and knee replacements coming. And then it is kind of up to the orthopedic surgeons and the hospital networks themselves to try to increase the benefit for the patients so that we have the best change in value. And our own little kind of microcosm of what we can control as surgeons is increasing the benefits to the patients, and we have elected to kind of focus on the technology aspect to improve people's outcomes. So again, just to kind of reiterate, in 2018, Medicare has essentially said that total knee replacements are no longer an inpatient-only procedure, which what that means is that they actually encourage people to go home. And the decision was not an arbitrary one. The decision came from years of data, and probably throughout the 2010s, we were able to compile large amounts of data that showed that people who do go home after their joint replacement surgery tend to do better. They have lower infection rates. They have higher satisfaction rates. And the ultimate step is then removing the surgery from an inpatient status altogether and allowing people to have a knee replacement and then be sent home that same day. Now, this is a very specific demographic of people that have the right health to allow them to go home right away. But it turns out that the majority of people do fall under this category. So how can we do this? Like, how are we able to, 10 years ago, require a patient to spend, sometimes even up to 4 or 5 days in the hospital, And then today, doing more or less a similar surgery, we're able to send the people home right away. Well, it has to do with the way that we do the surgery, the way that we control the pain, and the way that the system sets itself up to allow us to monitor you while you are at home. Patient selection obviously is a very important factor. People that are allowed to go home right away tend to be younger, they're more active, they have less comorbidities, meaning they have less medical issues. But it turns out that the medical issues that would preclude somebody from going home really are end organ damage types of issues. So as long as your heart function is strong and your lung function is strong, and you don't have any sort of major kidney damage, turns out that it is a safe maneuver to send you home right after surgery. Again, patient engagement and learning about the surgery and talking to friends and listening to kind of our model of what the expectations of the surgery are allows you to not have the anxiety about going home. But in the end, what we're able to achieve with some of the pain reduction techniques and the smaller, less invasive surgeries have really opened up the way for this. So again, just to kind of bring it home, outpatient surgery is safe. We know this from very large cohort studies, and people do very well. They actually tend to enjoy their outcomes even more. What I tell my patients is that if you go home, you have to use your stairs. You have to be able to get up and walk to the kitchen, walk to the bathroom. This is the same level of therapy that you would be doing if you were in a hospital. And when you are in your own environment, it also carries along an additional benefit of having occupational therapy, because you know how to navigate your own steps. You know how to navigate your own kitchen, your own living room, and it allows you to have a much safer recovery. Again, at 90 days, no study has ever shown a difference in complication rates, readmission rates, or reoperation rates from outpatient versus inpatient surgery. And again, the satisfaction rates are extremely, extremely high. So what is it about pain control that allows people to go home? The traditional pain control modalities were what we call reactive. You had pain, you took a medication. And oftentimes the medication was an opioid medication. It turns out that this is not a very good, and it is not a very proactive way of treating pain, because it's oftentimes hard to catch up on pain. So today we focus on something called multimodal pain analgesia. So preoperatively, you get a concoction of medications that each target one of the different pathways of pain. You get a central acting medication, which is acetaminophen, Tylenol. You get a nerve desensitizing medication, a gabapentinoid, whether it's gabapentin or Lyrica. You get some sort of anti-inflammatory to prevent the post-operative reaction to the pain. And then you get a long-acting opioid, which is the less addictive forms, and it has a less of a adverse effect during your recovery. You also get a regional block, which these days is being done with the spinal surgery. And the very simple idea is that if we can prevent the body from ever feeling the pain during surgery, then when you wake up, the body doesn't really realize that a painful operation took place. And people forget that even though you may be under general anesthesia in the past, your body still feels that pain, and the anesthesiologist certainly feels that pain, because they have to constantly keep upping the amount of narcotic medications to keep you sedated. So if you can take away your body's perception of pain through a spinal block, then the anesthesiologist is there really just to monitor the breathing and make sure that you are not agitated or anxious during the surgery. So with these types of modalities, we have shown that we can easily minimize your post-operative pain, and people during their first probably 3 days experience very little pain. This allows people to go home very quickly, and it also decreases the need for narcotic medications. Now, what can we do as surgeons? Well, there is something called less invasive surgery, LIS or MIS, minimally invasive surgery. And the very, very basics of it is the less tissue damage that we cause, the less swelling, the less nerve pain, and the less pain overall is experienced by the patient. So keeping the incisions smaller and doing some of these newer kind of approaches does really, really move the needle to allow you to recover faster. So in terms of knee replacement, what this looks like is this. So the gentleman on the right-hand side of the screen has what's called a more traditional knee replacement. You can see that it is somewhere between a 10 and 12-inch incision. You can imagine that that incurs a lot of pain because there's a lot of tissue that's now has to heal, and healing tissue swells. Swollen tissue hurts. So the two patients on the left are two of my patients that had a total knee replacement, and you can see the picture in the middle. It's very hard to see the incision at all because the tissue heals very quickly, but it is approximately a 3.5 to 4-inch incision, as is the lady on the left. So these smaller incisions really allow for the tissue to resuscitate much quicker, and allows the pain to be controlled much better. So coupled with less invasive surgery comes the idea of partial knee replacements. So we used to routinely do a total knee replacement because it was the only surgery that was available. You would remove all the cartilage in the knee and essentially try to rebuild it. Now, for the vast majority of people, not all the cartilage is damaged. And as technology improves, we are trying to tailor surgeries to only address the part of the knee that's damaged. So in early stages, you may have just a small amount of wear, and as the arthritis progresses, it may encompass the rest of the cartilage. But for many people, the arthritis never progresses, or that it progresses in such a low rate that a much smaller surgery can give you excellent recovery for a long period of time. There are good studies that show that in appropriately selected patients, partial knees can last as long as total knee replacements. And we are now doing our best to kind of tailor the surgery that's needed to the bare minimum that's necessary to allow for pain relief. Now, not everybody's a candidate for partial knee replacements. In general, I believe that in my practice, it is about 15%. There are other surgeons that rate that number as closer to 30%. And the honest truth may be somewhere in the middle. But if you are a candidate for a partial knee replacement, it is a very good option for you because your recovery is essentially cut in half. Partial knee replacement looks like is what you see on the left here. The white cartilage is the patient's normal cartilage that is completely intact, and we just removed a little segment of cartilage over the inner or outer or patellofemoral aspect of the knee. Compare that to a total knee replacement where everything that's in that gray color is actually a metal cobalt chrome alloy that's used to cap the femur itself. And the way that a partial knee will look on x-ray is very minimal. So if you look at it, you can see that the patient here has normal joint space on the lateral, which is the outside part of the knee, that we have now restored joint space on the inside part of the knee. And from the side view, you can see it's really just a small cap, almost as if a dentist was capping a tooth that we put over the surface of the joint to allow for smooth motion. The patient on the right side had a lateral uni, and that's the benefit of partial knee replacements, is that we can really kind of tailor the surgery to where it's needed. There are effectively 4 different what we call partial knee replacements. There is the medial uni that addresses the inner surface of the knee. There's the lateral uni that addresses the outer surface of the knee. There's the patellofemoral uni that addresses the space behind your kneecap, which is oftentimes a commonly worn part of the knee. And as we begin operating with robots and are able to really kind of narrow down into exactly the worn aspect of the knee, we see that you can even do bicompartmental, that you can sometimes do a medial uni and then also combine it with another partial knee, which is very important because the question I get oftentimes is that if somebody may be in their mid-60s or even early 70s and I offer the idea of a partial knee replacement, people's knee-jerk reaction is to say, well, if other parts of my knee will wear out, I'd rather have the whole knee done right away. It's certainly an option, but it is a more painful option sometimes. It's a different recovery, and a total knee replacement, no matter how nice we can make it, is still a fake knee. So if you can, regain the use of some of your ligaments, and that we can isolate the replacements to partial knee replacements, even if we have to go back in the future, again, these operations are such quick healing times that there may be a benefit to this type of strategy. So this is a patellofemoral knee replacement. You can see it right here. It just kind of resurfaces the wear behind the kneecap. And this is kind of an interesting case. If you look at the image on the left, that's what a partial knee candidate would look like. They have normal cartilage space on the outer surface. They have no cartilage space on the inner surface. So the surgery that we did for her is this middle slide right here. And unfortunately, in the probably 2 weeks or 3 weeks after her surgery, she had experienced a fall, and she fractured the outer surface of her knee. And it's kind of hard to see, but I kind of outlined the fracture line in red. And whereas most people would say, you know, this may be somebody who now has to have a total knee replacement just a few weeks after having a partial knee replacement, the options using robotics are that you can now do a secondary partial knee replacement. And we replace the outer surface of her knee, and she now has 2/3 of a knee replacement that functions very well for her, and it still feels like a normal knee replacement. This here is a small little video just to kind of show you, and I'm not sure if it's going to play, but it might, just what a resurfacing partial knee replacement looks like. And here, I'll play it now. I'll just play the first 30 seconds or so, but it takes it through a range of motion for the knee. And as you can see, as the knee bends, you can see where the cartilage is scuffed off. And this is very much what a arthritic knee looks like. So once that cartilage is worn, there's unfortunately nothing else that can be done to replace it. So for those people who are candidates for partial knee replacements, the surgery effectively entails removing that segment of the knee and replacing it with a metal alloy, and the bottom part of the tibia replacing it with a high durability polyurethane, a polyethylene liner that acts like your new joint surface. This gives you a almost completely normal feeling knee because we're not removing any of the ligaments that give the knee its natural feel, but we do resurface the knee, which gets rid of the pain. So a total knee replacement, it's more or less a similar video. I won't show it here. And so how are we able to do such kind of a precise surgery that focuses on individual sections of the knee? Well, this machine right here, while it may look like a refrigerator with a crane on top, is a very impressive piece of technology, and it allows us to very precisely just remove the cartilage that's needed to be removed. Robotics is everywhere, and this is just something that I was reminded of last weekend, that even very simple things that we take for granted are actually made by robots these days. So these tees were made by robots, and they're promising 4 more yards for every ball that you hit. And while that might seem great, for me it just means that I go 4 more yards deeper into the woods. But the technology that's available, nevertheless, is very impressive to make these things happen. This again is the Mako joint replacement robot. Valley has 3 of these now. What allows the surgery to take place is a CT scan in its bare form. All those x-rays that I showed you are 2-dimensional images. And in the past, we used to look at 2-dimensional images and try to imagine what the knee looks like in 3-dimensional space, and then even more so try to imagine what the knee moves like in 3 dimensions. It's a very complex system, and even in the best of hands, it was sometimes conceptually hard to envision. But when you operate with a 3-dimensional plan, you get a 3-dimensional surgery. And what the robot does is that before your surgery, a CT scan is created, and we get slices of your entire leg that's on the order of a few millimeters, if not less. And because of this, we can actually build a 3D model. And what this looks like during surgery is the images that you see on the right-hand side, where we actually have your knee model templated over your exact bone. And any morphological or physiologic differences to your knee shape are captured by the 3-dimensional image. And then by using rotational tools, we can change the positioning of the implants to exactly match what your native anatomy is. And the precision is, if you can see, it's on half a degree control of rotation and half a millimeter precision in where we make our cuts, which is something that's just beyond the scope of any human being to be able to control their bony cuts, no matter how well we think we can operate. So the way that it actually looks like when we start operating is we're actually no longer looking at the bone itself when we're operating. We're looking at a screen. And as we remove the bone that's in the cartilage that's not supposed to be there, it turns from green to white. And we know that we've removed all of the cartilage in exactly the precise plan that we had templated before. After surgery, the x-rays look like they should. They're very precise. Whether it's a total knee or a partial knee replacement, it's very, very rare that x-rays show something that you were not expecting to see, which is what we call precision and accuracy. So, the question that oftentimes comes up is, well, how long has this robot been available? Like, I don't want to be getting I don't want to be the test subject on a new piece of equipment. It's not new technology. It's just, for a long time, been very expensive technology that, as all technology, has depreciated in its cost and is now available to just about everybody. So the technology has been here since 2006. We have now done way more than 83,000. This is a fact from a couple years ago. I believe that number has recently reached 200,000 Mako knee replacements in this country. So the technology is really picking up speed. And at Valley Hospital, it is now the only type of surgery that's done. And that's a good thing, because we can now hit our target precisely every single time. Does the robot actually do the surgery, which is oftentimes a misnomer. So this is actually termed robotic arm assisted surgery. So the robot does not go into autopilot. There's no pushing a button and the robot does everything by itself. What it is a very precise piece of equipment that I can, and all the surgeons can program to allow us to remove the things that we want to remove. And if we go outside of the scope of those boundaries, actually a piece of assisted technology that I control. So I actually hold that cutting device right here in my hand, and the robot kind of follows me and allows me to make the cuts that I've termed safe. So just a couple more slides, just has to do with surgical wound closure. Traditionally, staples and daily dressing changes used to be a mainstay of orthopedic surgery. It's why a lot of people waited in the hospital, because we needed to see that the wound was clean. People were not allowed to shower for a long time because of this. And while staples are still used, oftentimes we can divert to different types of skin closure systems. This is what we call a EXAFIN fusion, and essentially it is a glue strip that goes over your incision that is waterproof and that allows the incision to remain safe and sterile while you do shower, while you do physical therapy, and it has incredible strength that we can actually let people go home with it right away. On top of that, we use special antibiotic and silver impregnated dressings that are, again, antimicrobial. They're waterproof. The dressing on the right-hand side is called a Aquacell. It can actually go underwater. It's been tested to do that. I wouldn't advise patients to do that because it can always start peeling off inadvertently, but it can certainly withstand shower spray, and it keeps the incision completely moisture-free. So, what is the recovery like? Very quickly, robotic surgery has allowed patients to recover much quicker. So a typical patient, I would say, will, in the first 2 weeks, while waiting for the incision to heal, be allowed to move from 0 to 90, maybe slightly over that. They can shower right away. They're allowed to fully be weight-bearing and walk, and physical therapy starts on day 1. By week 2 to 3, we transition to outpatient physical therapy that's more focused on strengthening, as well as getting your range of motion to what we term a functional level, which is 0 to 120, 125 degrees. And by week 6, you're now at a stage where you're just allowing the tissue to heal. So while there will still be some pain and there will be some, sensations that are not necessarily termed as normal. You have now completed the hardest part of your journey, and it allows time to take care of the rest. So, just the last slide, I always have to put almost a disclosure is that, joint replacements are artificial parts of our bodies. They do not heal. They do not have blood supply. They don't have the capability of fixing themselves like most of our body parts can. So there are certain, sports that we term low impact activities, and this includes walking, golf, hiking, yoga, swimming, cycling. The honest truth is that this is really what should become the mainstay of your activities after a joint replacement, because the hope is that this implant will survive the rest of your life. And the more running activities you do, there's always the potential that a plastic piece may break, a metal piece may become unbound, and it's something that most of my patients are able to live very happy, active lives without needing to run or jump on their joint replacements. So that concludes the total knee and partial knee replacement of the talk. I will send the presentation back to my partner, and he will take it from there.
You're muted, Dr. Pizzurro.
Hi, Dr. Pizzurro. Can you unmute yourself?
Yes.
Thank you.
Thank you. So total hip replacement has been around about 70 years. It's been designated by the National Institute of Health as one of the most successful medical interventions there is. Every year in the United States, about 300,000 to 400,000 hip replacements are performed, enhancing the lives of many, many people and getting them active. And for some people, it's just simply walking. Other people getting back to activities ranging from hiking and golf to skiing, snow skiing, water skiing, etc. What we're actually replacing is we're taking out the ball of the hip and we're going into the socket. We're cleaning out the cartilage and some bone. We're putting in a titanium cup, and then we're going inside the center of the femur, the thigh bone, where we're either putting in a stem most of the time without cement, or sometimes the bone's a little soft with cement. This video here will depict. We don't really take off the skin and muscles like this, but just getting down to what at the heart of the procedure, what we're doing is we're removing the ball of the hip and repairing taking out the cartilage, and that's where the robot comes in specifically for that part, preparing that bone, which used to be challenging to do accurately every time. And you can see a stem goes in there, and nowadays on top of that stem we put a ceramic ball, and the ceramic ball moves inside the polyethylene socket. So going back to what Dr. Dizdarevic said, some fiction would be that the robot is capable of doing the surgery without any human guidance, and that the surgeon goes to the break room and drinks coffee, that you don't need a CAT scan, you can use x-rays, that the robot requires a longer surgical time and is more invasive, and that the robot inundates the staff with more work to do, more trays, and makes everything harder. Well, the facts are that we need the robot is really a tool. It's an instrument that we use. It can't do the surgery without us. There's a preoperative CAT scan which lets us plan your surgery in 3 dimensions. It's incredibly accurate, like Dr. Dizdarevic said, going down to 0.1 millimeters. We're making, it's coming as close to we can as having a custom procedure where it's fit to your bone. We determine the exact size of the components based on the CAT scan and how we want to put them in. It's used for partial knee replacement, total knee replacement, and total hip replacement. And the total hip replacement can be done through any approach. Again, the preoperative planning is considerably enhanced and accurate. For our staff there in the room, it's actually easier. There are fewer trays involved. It's easier turnover, and there's a smaller inventory because we really know within one size what implant we're going to use. So the three key benefits to the robot are, number one, it's enhanced planning. Whether it's a knee replacement or hip replacement, we can look at how we want to put in the implants. We can really visualize all the deficiencies in bone or the bone spurs. And then there's something called dynamic joint balancing, which simply means once we're in the operating room and we've registered the robot with your bone, I can actually take a probe and put it on your bone and look at the computer screen and see where on the CAT scan model I am, exactly where I am. And that we can also do measurements down to the 0.5 millimeter of how loose or tight your knee is. We can measure hip leg lengths, and there's another measurement I'll show, offset. And then the last part is it's actually the execution of the surgery. We bring in the robotic arm, and whether it's a saw or a reamer, we can use the robotic arm, and it's actually safer. The robot doesn't let us go outside where we want to go. It doesn't let us go to a danger zone where there's a nerve or blood vessel you don't want to harm. It doesn't let us go through the bone into your pelvis. In the past, years ago, I would sometimes get called to emergency to the operating room as a problem, and now this protects against it. So total hip replacement has excellent longevity, which means 10 years, more than 95% of patients are doing well. If you look at 20 years, it's more than 85%. What's the goal with the robot is really to enhance the satisfaction and the durability and the stability of the hip replacement by putting components in a more accurate position. We're better able to equalize leg lengths and make what we're doing reproducible. So instead of getting exactly what you wanted 8 out of 10 times, you're going to get it 10 out of 10. So you would say kind of like, well, is this really effective? What's it going to do? And the question is, can we really make these procedures better with the robotics? And the answer is yes. Scientific evidence published in literature is with the hip replacement, there's excellent accuracy and precision with regard to the cup position with equalizing leg lengths and then offset. And I'll show you in a moment what offset refers to. In the studies that are performed, 100% of the cups were in what is a determined safe zone when the robotic arm is used versus 80% for when it wasn't used. Patients have reported improved outcomes. In other words, they're doing better with the robotic than with the manual procedure. And some studies have showed that patients are back on their feet and leaving the hospital earlier. So this just shows you what we actually are doing. Like that's a surgeon holding the robotic, the instrument, the tool on the robotic arm, which in this case is a reamer, which if you look, it looks like a cheese grater, and it's actually used to remove the cartilage in the hip socket and some of the bone. One may ask, for the surgeon, is there a benefit? It actually, there was a study that showed less mental stress, physical demands, complexity. Surgeons felt better and they had greater satisfaction when using the robotic arm. So for us, we start with a 3D model. We have CAT scan, put into a 3D model on the computer. We can size the implants. Then we have in the operating room, we check the plan. We go in, we register the extremity with the robot. We put like antennas, we put pins in the bone, and it has an antenna we call an array, and it registers with the robot. And then we can do measurements and execute the plan. So whether it's a hip replacement, a partial knee, or a total knee. So, has technology helped? Doing a hip is easier, and it's, you're more likely to get the cup in the right position, less likely, therefore, to dislocate. And we're doing a better job of recreating patient's anatomy, which the feeling is that patients are feeling better ultimately, but also feeling better early. So this is a 68-year-old male. He has right hip pain. He has severe arthritis. He's worn out all his cartilage there. And the old way, we used x-rays. I had a marker there. It was 25 millimeters, and we put these templates on, which is actually with a computer. And I did some measurements. And now this is the new way. I have a 3-dimensional model. I decide exactly what position I want to put the cup in, 40 degrees and 20 degrees. I noted that the leg is 2 millimeters shorter before surgery. And in this case, we decided on a 58 millimeter cup, a size 7 stem. And we know which their stems come in a little bit different variety. And that's the plan we want to execute. And that's the post-operative x-ray. And if we look, that's on the right. This was a computer-generated model. And then this is the actual x-ray and the recovery room after surgery, and they look strikingly similar. So 3D templating yields accurate, excellent accurate sizing of the cup and stem. So the people working with us know what size implants to have in the room. The robotic arm is safe. It's bone conserving. It doesn't take too much bone. It takes just enough, and it's actually time conserving. So this is reliable. The surgery takes X amount of time. When we're not using a robotic arm, there is some significant variability, and ultimately leg lengths are more easily equalized. So again, 68-year-old male, the old way, new way. This is offsets a measurement of how far out the hip goes. And you can see it's measured down there. And I want to put your hip in that right position. I don't want it too far out or too far in. I want your muscles to feel like this is what you always had. So this is the plan that the cup's going to look like. And what I do is we actually put in the cup, and I look and I see some overhanging bone and I see some cup here. And when I put in the cup and I can look at the screen, I see that they match. I know I've done a good job. This is actually doing a hip anterior approach. I took away some slides. I didn't want this to be a graphic or horror movie talk for you all, but this is the robotic arm going in there to prepare the socket. And on this side of the room, you can't see there's a monitor I actually look at. You look in the wound, but you spend more time looking at the monitor. And the robotic arm is safe. It's safely in there. It's not damaging any of the surrounding muscles, which we've gone between. And in this video, if we get this to play, it actually shows the preparation of the socket. In this case, the green is the bone I want to remove. And because I want the socket to press fit in there, and the socket's a little bit bigger than what you prepare for, I actually go to a little bit of red, which is 0.5 millimeter more. So you'll see here, it looks almost like a video game. And you can see it's preparing us for how much bone we're going to remove. You see, remove all the green, and we get down till this is all zeros in there. And then in the next slide, so we've prepared the bone. Now we're going to actually put in the cup. So this is the cup going in, and you see a measurement, 14 millimeters is how far out it is when I start. So I want to get it to 0. So here it's being impacted, and it's confirming I'm doing it in the right position. 40 degrees and 25 degrees. You see I hit 0 there. So I've got the cup in the correct position, and I look at this, and you can see here that I have some overhanging bone, and then here the cup's exposed, and that's the planned position. That's exactly how I wanted it. And when I look in the wound, I'm able to look at it and see that it exactly matches that. And the robot confirmed I was in the right position, and then visually I'm looking inside the wound and I see it's the correct position. So when you have this patient who has a total hip on this side and you want to equalize the leg lengths, you easily get them to this. So again, the advantages are I determine the cup size with the CAT scan. I've actually doing about over 300 of these hips, have never changed the cup size. The cup goes in reproducibly to a predetermined position. It conserves the bone. It doesn't take away too much bone. There's less struggle with it. And as a result, getting the cup in the correct position means you're less likely to experience a dislocation or have a leg length discrepancy. Also, determining the stem size is important. It's an excellent guide. I want to make sure I don't make the stem size too small, and if I make it too small, it's possible you're walking afterwards and the stem goes down, or you could fracture. And the same token, you don't want to make the stem too large that we break the bone in surgery. And again, leg lengths. We want to make your leg lengths equal. So a couple of other issues is, risk factors. In assessing patients as a potential candidate for hip or knee replacement, we really look at risk factors, and that's where a lot of the focus is now. We want to make these surgeries more successful. We want to reduce complications. So things like smoking. Smoking is associated with a dramatic increase in complications such as wound healing issues, which relates to infections, as well as blood clots. And then you have pulmonary risks. So we really ask patients to stop smoking. We are starting more of a program. We're getting patients to stop smoking minimum we want 4 weeks. Sometimes we'll negotiate to 2 weeks. But in the near future, like other hospitals and centers across the country, there's going to be blood testing. Diabetes is a known risk factor for infection and failure of a hip or knee replacement. We look at the patient's blood work. We look at a hemoglobin A1C, which is that blood test your internist or endocrinologist orders every 3 to 4 months, and we want to see a value of 7.5 or less. If it's elevated beyond that, really the standard of care is becoming to hold off on surgery and get the diabetes under better control, so that we can reduce infection rates. Patients who have the surgery and afterwards are running blood sugars over 200 for many days, they increase their risk of infection by 5 times, in other words, 500%. So we want to address this beforehand and minimize risk. We're going to have much happier patients, much more successful surgery. Another one is some patients come in to see us and they're on narcotic pain pills. Sometimes they're on it, they have a neurological condition or they have chronic severe back problems, they've had multiple back surgeries, and that's a different issue. But if you have knee arthritis, hip arthritis, and you're on narcotics, there's an associated higher risk of failure of their surgery, high risk of complications, and there's a lot more difficulty managing pain after surgery. So that's a time we have a discussion about being able to cut down on the use of the narcotics, reduce it by 50 to 70%. We find we have more successful surgery and a much easier rehab. Hip approach, a common topic people hear about and read about online is the approach. Anterior, which means going in the front, and posterior, which is the traditional going in the back. I personally do about 70% anterior, but I'll tell you that the fact is both of them do well. If you look at the literature, the scientific literature, you get into a journal, you get 3-4 months out, the results are excellent for both. Anterior approach, I would say, has fewer restrictions, and in some ways a faster return to walking without a walking aid. Pain-wise, studies don't show that there's less pain with the anterior approach. Posterior approach, patients do very well. They actually equally go home the same day. You do have a couple of simple restrictions, and usually when I show patients what the restrictions are, the comment is, oh, I can't do that anyway, or I don't do that anyway. It's not an issue. Not everyone is a candidate for anterior approach, so I really do screen the patient and decide. Some of you might go to a hospital or a group and see a surgeon who does a direct superior approach or lateral approach, and there are good results with those approaches as well, and the robot can be used with those as well. Dr. Dizdarevic touched on the whole discharge, and majority of patients are going home now safely the day after surgery. The comment we hear is, patients, they're happier at home, they sleep better at home. I think Valley's food is actually pretty good now, but I think most patients prefer their food at home. Note for patients for knee replacement, if you're going to go home the same day, it's a good idea to ask for a physical therapy prescription, visit a therapist before you go in for the surgery, learn the post-op exercises. It makes it easier for you to start doing the night of surgery and the next morning. Patients who do have a lot of medical issues, heart, lung, chronic heart, lung, or kidney disease, they're probably going to stay in the hospital longer. If you have poor balance, you're probably going to stay in the hospital longer. Our nurses and therapists will not let you go home unless you're safe on the stairs, and safe getting out of a car, and medically optimized for doing so. We want, for patients going home, for this to work, we all need to be on the same page. We need to make sure you're safe to do it. Less than 10% of the time nowadays, patients go to rehab center, and we really, we want patients to be doing the best possible. Infrequently, that is, for some patients, it's a rehab center, but we have that discussion before surgery and with the team at the hospital. They also address it as well. COVID-19 is the elephant in the room here, and what safety measures are there? Are we still doing these surgeries? So Valley Hospital, we've done over 380 hip and knee replacements going back to May. In May, there were between April and May, there were about 9 patients who came in with hip fractures and had total hips. These 380 patients, none of them have contracted COVID during the hospitalization. Patients have done very well. The policy currently is that We do a nasal swab through the hospital. It's a PCR test. It's done 4 days prior to surgery. They do it every day of the week. The hospital sets that up with you. And after that test, you go home and you quarantine until the time of surgery. Any positive test, you're going to have your surgery postponed for at least 14 days. Okay. And the hospital works it out with you. Typically, you have it postponed 14 days and you're clear to go as long as the patient is asymptomatic. Thank you very much for your time. I apologize for the technical glitches. I think the technical glitches is kind of like the 2020 year we've had. This is actually a picture from October of 2019 from Napa Valley, and unfortunately, a lot of this area has been scorched by a wildfire. But we're all kind of hanging in there and moving along. And right now, we're fortunately, we work with a great team at Dr. Dizdarevic and I work with a great team at the hospital, Valley Hospital, and we're really helping a lot of people. And the plan is we're going forward with it. We're planning through the end of this year into 2021. We're going to keep forging ahead, taking safety as a primary concern for everybody. And that's it. If you have any questions, I think Parmender's can help us, so we can have you ask them. And we can address any questions.
Hi, everybody. Thank you so much, Dr. Pizzurro and Dr. Dizdarevic. That was great. Again, we apologize for the technical difficulties. Dr. Pizzurro put it well. It sort of mimics this year, right? But we are getting there, and we appreciate your patience so very much. Doctors, just a couple of questions. I like this one. I can relate to it. Very simply, if I get my knee repaired, is the arthritis still there?
I'm muted.
You're muted?
Yep.
Okay, I think I hear you guys. So if I get my knee repaired, is the arthritis still there?
That's a good question, and I hear that question every day. It's not. So arthritis is the process of losing cartilage. So once the knee replacement or the hip replacement is performed, there is no more cartilage to lose. So arthritis itself is no longer even a possibility. With that said, I spend a lot of time talking about partial knee replacements. If you have a partial knee replacement, that means that 2/3 effectively of your knee can still have healthy cartilage. If that healthy cartilage was to progress or get damaged for whatever reason, then yes, you can have osteoarthritis in a separate compartment, only in the setting of a partial knee replacement. But in the setting of a total hip or a total knee replacement, you can never have arthritis again. You can have pain, but it won't be arthritic pain.
That's great news. Okay, another question. Somebody had 15 years ago a repair for 2 torn meniscus, ACL replacement. Two months ago, this person says my X-ray showed I need a new knee replacement. 54 years old. They said it was suggested that the person does spin, swim, a little walking. Too active not to walk. Basically, what they're asking is, how many miles would you suggest someone walk per week? With little cartilage on the left side, then on the outside of the knee. So I guess just how many miles could someone walk? Just you take yourselves off mute if you can. I think you're on mute.
Sorry, in that situation, hit F10. The activity you do, so if you have end stage arthritis, it really depends on like how you feel. There's not a specific number. Often for knee arthritis, patients using a stationary bike or elliptical will be able to do more activity because it's non-impact and can do more. The walking depends on what you can do. Arthritic joints in general feel better when you're moving them. If you're sedentary, they tend to become stiff and become more painful, and then you actually start to lose more motion. With arthritis, you want to move the joints in a low impact fashion, maintain your motion, and typically that's the way you have the least pain. For people who are not using stationary bikes and it's an arthritic knee or hip and we're recommending it takes some getting used to. The first couple times you use it, you may have a little bit of soreness, But a lot of people, if they persist with it, using it 15, 20 minutes a day, little to no resistance, you can work up to it and do more. But it really ultimately, how many miles you walk or ride depends on how you're feeling. So it's an as tolerated activity.
Okay, thank you. Also, someone writes, I have 2 comorbidities, but have severe arthritis in my hip. Would this person still be a candidate for hip replacement, they're asking? The 2 significant comorbidities.
Comorbidities are like kids. No 2 are the same. So it all depends on what the actual complication is. Just about everybody, right, will pick up medical problems throughout their life. The older we get, the more medical problems you tend to have. The ones that are really critical for us are the ones that affect your breathing and your organ function. So cardiac disease, whether or not you have heart failure, whether or not you have any sort of severe respiratory illnesses, any recent, infections, blood clot histories of cancer. Most people, I'll tell you right now, end up being candidates for knee replacement surgeries because the surgery and hip replacement surgeries, because the surgeries themselves are safe. The problems that people kind of encounter tend to be after the surgery. So for people that have organs that are starting to kind of diminish in their function, it doesn't mean that the surgery itself will be any less successful. What it may mean is that it puts undue pressure on an organ that's already having a hard time functioning. So you may still very well be a candidate for a knee replacement or a hip replacement, but it's a conversation that we, as the orthopedists, have to have with you, but also with your medical doctors. So, the one thing that we didn't really mention today, and we should have, is that this is a team, right? I do the part in the operating room, but afterward, your medical doctors are continuing to watch you preoperatively. There's going to be involvement of cardiologists, pulmonologists, your family doctors that know you better than we do. And the decision on whether or not to proceed or be a candidate is not just ours. It's a family decision. It's a decision that you yourself make. It's a multi-specialty decision that a few doctors get involved with. And I think getting you to have a successful outcome and a happy outcome in the end is all predicated on communication between all the parties involved. So just having 2 comorbidities, I would say, does not necessarily preclude you from a joint replacement surgery.
Okay, thank you so much. And just another question, someone asked, how frequently can gel in the knee be used?
Medicine is advanced considerably that in the 1990s, people were discussing knee and hip replacement and people in their 80s, and they were like, wow, we were able to do this successfully. Here we are in 2020, and people in their 80s have successful hip and knee replacements all the time. It's very common. So in that vein, medicine, the whole field of medicine, every field has advanced.
Oh, thank you. Thank you. I didn't mean to interrupt you. And just someone asked, how frequently can gel in the knee be used? That makes sense to you?
Gel hyaluronic acid injections or viscosupplementation injections typically can be used every 6 months. You usually just need approval through the insurance, and they carry a risk of less than 1% of the time it could irritate your knee and cause like an inflammation or synovitis that requires treatment. It's not common. It's less than 1%. And those are usually best utilized in people with less severe arthritis. If you're coming in and you've seen your x-rays or been told you have bone rubbing on bone, most likely the gel shots are going to be of less useful for you.
And just to add one more thing, there's a lot of alternative, injections that are now available. Lots of those have never really shown a clinical benefit. Just because something can be injected into the knee doesn't necessarily mean that it should be. So they're specifically talking about osteoarthritis because it's widely available right now. There's never really been any good scientific data at all. There's one clinical trial right now out of the Mayo Clinic regarding stem cell injections for osteoarthritis. These things are usually not covered by insurances. They're very much experimental. There's been no efficacy shown for an arthritic knee to reverse the arthritic process or improve your pain. So sometimes I always like to tell people that just because something is available doesn't mean that it's something that should be available to you. So right now, the only 2 injections that have really shown efficacy is steroid anti-inflammatory medications of some sort, gel injections. The two injections that are now starting to show something involve something called Zilretta, which is a long-acting steroid, and PRP, which is using your own growth factors from your blood to see if that can potentially offset the arthritic pattern. But stem cells, I oftentimes implore people to not get into that because sometimes it's a very expensive thing to try to guess on, so to speak.
Well, thank you so much. I think we're going to wrap it up now. Thank you guys so much for your presentation. It was excellent. We really appreciate Dr. Pizzurro and Dr. Dizdarevic and appreciate everyone's patience and tuning in today as